So we're talking about the monocular elevation deficiency in the children. Sometimes they happen math symptom. That means the patient have the associated with the adduction or abduction deficiency and also dosing or serotosis. So please for your presentation.
Good afternoon, everyone. Today I represent for Department of Pediatrics Ophthalmology to present monocular elevation deficiency. Monocular elevation deficiencies were known as double elevator palsy, the combination of suprarectus and inferior oblique muscle palsy, but now is clearly known as the limitation of elevation of the affected eye from any position of gaze. The suprac is the main muscle responsible for elevation of the eyes in abduction and adduction. Therefore, the defective elevation can be explained by presence of the suprac palsy alone, or inferior rectus palsy restriction, or secondary inferior rectus contracture, or unilateral supranuclear lesion. A demographic, the average age of the presentation is 11 to 40 years old, no gender and no size predisposition. MAT can be congenital or acquired. A congenital case of MAT occurs sporadically, including 3 types. Type 1 is primary inferior rectus restriction, which is the most common, accounting for 70%. Type 2 is primary suprarectus palsy, and type 3 is supranuclear. Acquired cases are usually caused by trauma, cerebrovascular disease, hypertension, thromboembolism, sarcoidosis, syphilis, or tumor. Patients can present with the following complaints. Firstly, they cannot look up in all positions. They have a vertical deviation with or without ptosis. Next, they may have a normal head posture or diplopia or reduced vision due to amblyopia. And up to 50% of patients with MAT and droopy eyelids also have a problem called marked jaw wrinkling. The side of the MAT, there is hypertropia of the affected eye when the normal eye is fixing, and hypertropia of the normal eye when the affected eye is fixing. Next side is elevation efficiency in all gaze. This patient in the primary gaze have a hypertropia and ptosis in the right eyes, and when she look up, both right side and left side there is a limitation. This boy is similar at primary position. He has hypertropia and ptosis in the right eye, and he has a limitation of elevation. Next side of ptosis, which can be associated with hypertropia because of the facial attachment between the levator palmar superiors and superior rectus muscle. And though ptosis can be present in primary gaze when the fixating with the normal eyes. However, when covered the normal eyes, hypertrophic taken up fixation and eyelids move up. And Bell phenomenon is typically absent in type 1 and type 2, but is usually present in the case of MAT, resulting from supranuclear defect. A normal head posture, most commonly in patients have a chin up. If binocular fusion is present, a normal head posture may be not present if the affected eye is here. Amplophia may be present if there is a constant deviation if affected eye, ptosis or anisometropia. And finally, is the sign of upward saccade velocity is that it examined by asking the patient from to look from the one target to another quickly, look down and upside. This table is to present the difference between the tip. In tip 1, fork reduction test demonstrate a tight inferior rectus. The upward saccade are usually normal until stopped, and Bell phenomenon is usually poor. In tip 2, fork reduction test is free and upward saccade are slow, both below and above midline. Bell phenomenon is usually absent. In tip 3, is characterized by intact or midline reduced vertical saccade velocity below midline, but a normal or absent velocity above midline, and the fork reduction test is unlimited. The following condition should be differentiated from MED is a Brown syndrome, Duran syndrome, third nerve palsy, craniofacial, and congenital fibrosis of the extraocular muscle. Is different diagnosis of acquired MED, including acquired inferior rectus restriction, including the orbital fracture, terrorist eye disease, orbital myositis, orbital inflammations, and so on, and acquired super weakness, including the third nerve palsy, the CPO, myasthenia gravis, and other. The management of MED include non-surgery and surgery. Non-surgery include refractive error correction, amblyopia treatment. And for surgery, the indication for surgery is a vertical deviation in primary gaze, deviation into amblyopia, diplopia in primary gaze, and restricted binocular field. The goal of surgery is to improve the position of the affected eye in primary gaze by increasing the field of binocular vision. For surgical correction of MED, the procedure of choice is determined by a fork reduction test, which ascertains whether the cause of periodic or restrictive. In the patient with the positive fork reduction test, inferior rectus recession is the first choice of management. This article shows the result of surgical management in MED type 1. The main technique is inferior rectus recession in affected eyes. They reported that after the inferior rectus resection, the amount of vertical deviation corrected were 15 PD for near and 17 PD for distant. The patient residual hypertropia were undergone the second surgery by a suprarectus recession in normal eyes. After the second surgery, 77% patients achieved success. If there is no restriction, canal procedure can be performed. Other options include resection of the lateral suprarectus muscle or resection of the contralateral suprarectus muscle. In the case of a large deviation, we can combine the inferior rectus section with the canal procedure or augment canal or modify Nishida. This picture shows the canal procedure. The medial and lateral rectus muscle are transferred to insertion of the suprarectus muscle. For the case with an associated with horizontal deviation, modified knap is another choice. In this procedure, the sub-half of lateral and medial rectus are placed near the superior rectus muscle insertion, which allows for correction of the horizontal deviation with the inferior half. Augmented knap procedure utilizes a knap procedure combined with posterior fixation suture on the horizontal rectus to increase its effect. In knap on the study, the procedure shows marked hypertrophy correction range from 21 up to 5 PD, average 38 PD, but it has a high risk of anterior segment ischemia. So Nishida showed his technique, which were original described for adult nerve palsy, can be used to correct up to 30 PD of vertical deviation and have a low risk of anterior segment ischemia. There's a patient, a girl 8 years old, and have met in the right eye, tip 1, for touching depth and positive in a primary position. She have hypertropia and ptosis in the right eye, and she have limit of against 4 degrees, and we decided to inferior rectal resection. And 2 months after surgery, she gained a good success at primary position. There are no hypertropia, and when she look up, there are a little limitation, but it's much better than before. A boy, we have a massive one, have a forward-lateral test positive, and with the inferior rectal resection, and after the surgery, he has a good result. So, and this boy have a mat in the left eye and forward-lateral test negative. He have a limitation in elevation, and the Nishida procedure were done, and he have a good result. So. And in summary, in the management of MEC, there are several surgical procedures. The most common is inferior rectus resection. We can correct 50 PD, and another procedure like knap, augmented knap, modified Nishida can correct a large deviation. I have some message at home. First, this is no longer called the double elevator palsy, and now it's clearly known as the monocular elevation deficiencies. Secondly, the forward-lateral test is the most important to determine surgical procedure. And thirdly, the tip 1 is the most common, accounting for 70%, and the first choice of management is in inferior rectus resection. And lastly, the knap can correct a large deviation, but have a high risk of anterior segment ischemia. And Nishida can have a low risk of anterior segment ischemia and correct up to 30 PD. And thank you for listening.
So, there's any question or comment from the audience? Have any question? So, I would like to ask Dr. Vanandas, first the patient with MEC disease, so we have a single kind method to surgery for the patient, and I know that for glass surgery, they have a six kind of glass and modify for superior and also temporal or nasal rectal muscle, and also associated regression of the inferior rectal muscle. And by this surgery, and we have do how many case with clamp surgery and treatments for the whole patient. And we have how about your result, and if you have much patient and we in the pediatric eye department, we have any publication about the monocular elevation deficiency syndrome.
In our department, this year we have about more 10 patients with math, and the first choice of management is inferior rectus recession. Like this patient, we did the recession, inferior rectus recession, and maybe she have a good result. She have a little limitation of elevation, and maybe we follow her in 2 months. Maybe she can need the second surgery, but I think at the time of present in after the first surgery, she have a good result at the primary position.
Do you have any study and publication about the surgery method?
Actually, we are going searching.
Not have a publication.
Publication?
No. No article.
Not yet. Maybe next year.
Yes. I think if you choose patient enough, you can give thesis for the master degree or doing this surgery, and you can have an article or publication. I know that India is very the highest population in the world right now, more than 1.5 billion people. But they also publication about just around 50K from 2 years. So if you have as many surgery, lab surgery, you can publication in the DC. I think is very useful and very good article.
Yes. Thank you, Professor.
Dr. Chow, yes.
Yes, first of all, thank you, Dr. Tiếng Anh, about the presentation. It's very good because now we know more about the Met disease, because before we always maybe miss the diagnosis from other disease. Like if the patient has a one eye unilateral ptosis, so sometimes we misdiagnosis, and sometimes we have a bilateral ptosis. We misdiagnosis with congenital fibrosis, extraocular muscle. So the first of this presentation of Dr. Vân Anh says that if we see the children with the ptosis, one eye or two eye, we need to do the to test the deviation and deviation of the muscle. We check the muscle function before we decide it's ptosis or something like in the this function of the extraocular muscle. And the other side is maybe it's this disease is very rare. Dr. Van Anh said that it's about 10, so it's about 2 or 3 years now. Because I think it's only 5 cases a year. And Dr. Huy now he has a student of the master to do the thesis about this disease. And we hope in next year we have the result and we provide the result of this patient of this disease. And the other side that because of the rare disease, and so it depends on the function test. So there are many choice. We have two main procedures. The first is the inferior rectus resection. If the function test is positive, but if the function test is negative, we need to do the NAP or the modify the NAP procedure, because if we do the truly NAP procedure, maybe the patient has an anterior ischemia. So that's why there are many choice of the procedure with the rare disease. So if we have the result, so I think we need take more time. And we hope next year we have the results about the Vietnamese patient in the population publication. Thank you.
Okay, thank you very much. Any question or comment? Dr. Cơ? Yes.
I'm not a pediatrician guy, so as usual, because that you have a shoulder, maybe I'm wrong. Then you think with your congenital ptosis or Turner Prodigy or Brow or Duan syndrome. Could you give us some key point to make the different diagnostic among them? And the second question, could you give us some advice how to do the indication? And I think that the milestone to the indication for surgery treatment. In what scale you can do the surgery, and the other scale you can improve situation by orthotics or something like that. Reflection as an error. Yeah. And you didn't mention about Nisida. Yeah. Modify. I didn't see in your slide how you can do Nisida, modifying Nisida. Thank you.
For different diagnosis in Brown syndrome is characterized by limitation of elevation in adduction, and with a wide pattern exotropia. And Duan syndrome diagnosed by the presence of growth or retraction in down gaze along with limitation of elevation in up gaze. The third nerve palsy, particularly if involving the superior division of ocular motor nerve. The craniofacial is, for example, the upper syndrome. For the congenital fibrosis of extraocular muscle, may initially affect the inferior rectus muscle and thus be misdiagnosed with mass, but bilateral presentation and involvement of other extraocular muscle have distinct guides. It means in mass only one eye